This is session 5A on Therapeutics. My name is Jesse Roman. I welcome you to this session. I'm at the University of Louisville. Today, we're going to introduce 5 lectures that I think you'll be excited about. I know that when I head back to work in Kentucky, which is only 2.5 hours from here this next week, all the patients are going to ask me multiple questions, but they're going to focus on one. What new have you heard about therapeutics? What new treatments do you have? So today we're going to focus on that in addition to some new data about biomarkers and so forth. But before that, we're going to start with a presentation from one of the abstracts that we had out there. And this one is about someone who obtained an honorary mention, Dr. Susan Jacobs from Stanford, who's going to talk to you about patient perceptions of the adequacy of supplemental oxygen therapy. Dr. Jacobs?
Thank you very much. Thank you. And thank you to the Pulmonary Fibrosis Foundation for inviting me to share this information with you today. So in contrast to much of the research that's clinical and genetic, based to investigate and determine and get new treatments for our patients, this information I'm going to share with you today is really focused on what patients are dealing with while they're waiting for new treatments, and that's living, many of them, with supplemental oxygen. I have no disclosures. So the background of this study took place in May of 2015 at the American Thoracic Society meeting. At the time, I chaired the Nursing Planning Committee, and we're tasked with identifying critical problems to address. And the consensus among the nursing clinicians in the room was that there was a significant rise in patient-reported complaints about various problems with their supplemental oxygen therapy. We therefore created a specific oxygen working group to address the problem. The following May, at the Thoracic meeting in Washington, D.C., this oxygen working group had a short lunch meeting in which we invited 17 multidisciplinary consultants, and the Pulmonary Fibrosis Foundation was there, all numerous advocacy organizations, home care, Medicare, and at that meeting, the consensus of the group was that there were intolerable barriers to adequate home oxygen services for our patients, but we did not have data or evidence. So the purpose of this study was to describe the frequency and types of problems that are experienced by adult supplemental oxygen users in the United States. So this was an online 20-minute, 60-item survey, patient supplemental oxygen survey, which was developed by this oxygen working group. The survey underwent multiple review and revisions by patient oxygen users, various professionals, different organizations, and advocacy group representatives to ensure that we were addressing the appropriate content, that it was understandable, and how long it took to take. The study was also approved by the Stanford Institutional Review Board. It was posted online on a link on the American Thoracic Society Public Advisory Roundtable website, and that link was also distributed and published on as many websites as we could identify, including national pulmonary rehab organizations, state thoracic societies, home care, chest clinics distribute this information to encourage patients to respond. Analysis included descriptive statistics, paired t-tests, chi-square, and we used ANOVA and some post hoc analysis to look at differences in responses among groups. We had 1,926 respondents fill out the survey. Age 64 was the average, mostly female, and we had representation from all 50 states. Most were retired. The most common work status was 41% disabled, only 8% working full-time, about half living in suburban areas, 28% in rural areas, and 21% in urban areas. 44% reported that they lived in a competitive bidding area. This is a specific contractual area that durable medical equipment companies participate in contract agreements with. 11% did not live in competitive bidding areas, and 45% were unsure. So the diagnostic breakdown of the respondents mostly were COPD patients, obstructive pulmonary disease, interstitial lung disease, 27%, pulmonary arterial hypertension, 18%, alpha-1 antitrypsin, 8%, LAM, or lymphangioliomyomatosis, 4%. And then we had a group of other, which included things like congestive heart failure, bronchiectasis, infection, some post-lung transplant patients, and just a variety. We asked how long patients had used their oxygen. Half used oxygen for a time between 1 and 5 years. About 32% used oxygen more than 5 years, and 17% less than 5 years. We asked about what kinds of needs they had. 60% reported using oxygen 24 hours a day, and a third used high-flow oxygen, which we defined as 5 liters or a setting of 5 or greater. 63% attended pulmonary rehabilitation. This made this group quite unusual. It was a very high percent. 65% of the patients reported they never had their oxygen saturations checked on the equipment that was delivered to their home. So we asked how were the patients educated about their oxygen. The driver was the most common source of education, 64%. 10% of patients reported no education about their oxygen. 8% were educated by a healthcare professional, and a variety of other sources were reported by 12%. In terms of healthcare utilization, we asked, it was a self-report, had you been admitted to the hospital or had you had an emergency room visit in the past 12 months? A third reported a hospital admission, and about 34% reported an emergency room visit. We asked the question, do you have any problems with your oxygen? And 51% of respondents answered yes. So some of the characteristics of the sample that answered yes, I'd just like to highlight. The patients, respondents who answered yes to having problems tended to be a bit younger, were more often female, were more often disabled, and those respondents who said they did live in a competitive bidding region were more apt to say yes, they had oxygen problems. We asked by diagnosis and broke that down, and you can see that the highest percent, or the highest percent of patients answering yes to problems were those with LAM. And these are, it's a very rare lung disease with women. They're young, they're usually diagnosed during childbearing years, and many are raising families, clearly working. So I think the impact, even though they were the smallest group, was significant. And then interstitial lung disease patients, you can see, had a 51% response of yes, having problems. The lowest group was chronic obstructive pulmonary disease, and then we had in between these other, and then this was the overall. Other characteristics of the group that reported having problems included the longer duration of being on oxygen, which is somewhat intuitive. Those patients that used oxygen more than 5 years had a 57% frequency of answering yes to problems. Also, the oxygen requirement determined how often patients had problems, and those that used it continuously or at high flow had a significantly higher response rate of saying, yes, I have problems with my supplemental oxygen. Residents, suburban patients reported a higher rate of problems. Rural, in this sample, was a lower rate. We looked at the differences across the United States broken down by the US Census Bureau regions and found no difference at all in whether a respondent said yes or no to having problems. I think the highest was out in the West, and the lowest was the mid-south central area. But it was roughly all around 50%. Other characteristics of those having problems related to healthcare utilization. They reported a higher frequency of hospital admissions as well as emergency room visits in the past year. Interestingly, attending a pulmonary rehabilitation program made no significant difference in whether you experienced problems or not. Being educated by a healthcare professional made a significant drop in reporting problems, and having no education had a significant rise in having problems. And if it was the driver, it was kind of a 50-50 break there. We asked 2 questions of all the respondents, and one was, how many hours does your portable oxygen allow you to be out of the home? And those are displayed in red. And you can see the most frequent was up to 2 hours, followed by up to 4. And then we followed that with a question, how many hours would you like your portable oxygen to last? And you can see the responses included up to 5 to 6 hours or more was the most frequent response there. What types of problems do you have? So this question was addressed at those who said yes, they had a problem. So that subgroup then went on to answer, what are those problems? And the most frequently reported problem was equipment malfunction. Second was travel oxygen problems, delivery problems. I'm just going to go down the list. I'm not sure how many you can read. Lack of portable supplies that I can manage. Lack of high flow, not enough tanks for activity outside the home. I can't change companies. Company does not respond to phone calls. Incorrect or delayed physician orders. Can't mix systems. That's meaning that if they're at work, they can't have a stationary and a portable, for example. Need liquid oxygen and can't get. Billing is not what I expected, and not enough portables so that I can work. So we then looked at the differences between diagnostic categories, and I'm really just going to highlight those that hallmarked what were the differences compared to the other groups for interstitial lung disease patients. And you can see that the interstitial lung disease patients tended to be a little bit older. They had the fewest women in their group. They were the highest group, they were the lowest group to use oxygen more than 5 years. And we think this is related to the progressive nature of the disease. And you can contrast that with those with the chronic obstructive lung disease, COPD, had a higher rate, and alpha-1 antitrypsin patients use oxygen for much longer periods of time. So they were quite different in that respect. The other differentiating variable with the interstitial lung disease patients is they were the group that had the most frequent use of high-flow oxygen. You can see they had 47% used high flow, compared to COPD, where only 18% used high flow. So these needs are very different, and they reflected in the problems that they are dealing with day to day. Other differentiating variables for the ILD population in this group made no difference. So if you were educated, it didn't matter what your diagnosis was, everybody was educated fairly similarly. The source of your education wasn't different if you had ILD versus COPD. And the same applied to the question, how much does your system limit your activity outside the home? There was no difference across categories. Everybody was equally impacted. So in discussion, this was the first survey to capture a significant number of responses from supplemental home oxygen users. They experienced problems that were associated with a greater use of healthcare resources, and the respondents' number of hours outside of the home was limited by a lack of functioning, physically manageable, high flow, and portable oxygen units. Completing pulmonary rehab made no difference in experiencing oxygen problems, which to me highlights the issue of equipment, service, and reimbursement that aren't mitigated by education. And interstitial lung disease respondents rated higher breathlessness off of oxygen and reported the most frequent use of high flow and had significant limitations in activities outside the home. So there were some limitations. This was only available online, so you needed a computer and have access. It was only made available in English. And 63% of this cohort attended pulmonary rehabilitation. And the national average, last published, I think in 2012, for COPD patients by Medicare records, around 4% of COPD patients attended pulmonary rehab. So we know that we got a very skewed group, possibly by the way the information was distributed. These are also motivated patients. They're connected to resources and maybe heard about the survey. So for the future, we need more data. We need data to really document the potential impact of competitive bidding and the reimbursement issues that surround the medical suppliers and the patient services on the other end. And we urgently need to collaborate as patient advocacy foundations with professional organizations, payers, to improve the problem documentation, education, and the beneficiaries' access to functioning and adequate equipment. This is Team Oxygen. This was a large effort. I want to acknowledge my co-authors that were incredibly supportive over the last year and a half. the American Thoracic Society that posted the survey for us, developed the Survey Monkey, and downloaded the data for us. My colleagues at Stanford, Dr. Wilson and Mooney, who helped with some of the initial survey development. Leslie Hoffman, who was a great editor in the final manuscript, and then all the consultants that met with us in that oxygen working meeting and who gave that initial input to the survey to really ensure that we were capturing important topics. And finally, to the Pulmonary Fibrosis Foundation for inviting me and allowing me to present this data. And most importantly, to all of our patients out there who are dedicating themselves to taking the home out of home oxygen. And this is something that's critical to change the thinking around oxygen therapy for our patients. So thank you very much.